Hey everyone, great to see you all. Thanks for joining us today at our symposium, our webinar, Acute PE, Advanced Risk Stratification and Outcomes in 800 Large Bore Aspiration Patients. This is sponsored by the PERT Consortium and supported by Inari. So two of my favorite subjects, PERT and large bore aspiration. I'm going to go ahead and share my screen here to get started here, folks. And hopefully everyone can see my screen now. And I'm going to just briefly introduce my colleagues here. I'm Vic Tapson from Inari and Cedars-Sinai. We've got Rich Chanik from UCLA, who's going to talk about some of the long-term aspects of PE. Jason Berger from Florida, who's going to talk about risk stratification. And finally, Mike Jolly from Ohio, who's going to show us some great cases. So great to be here, folks. And then we'll do some Q&A when we finish. Well, I'm going to start by talking about the Flash 800 registry. There's some disclosures there for you. We're going to talk about large bore mechanical thrombectomy. I know most of you are familiar with this. This is the flow retriever system, which extracts thrombus by aspiration, and when needed, mechanical modes without the need for thrombolytics. And let's get started right here. So Catalin Toma presented these data first at TCT on September 18th, 2022. And he presented the initial data, and these data were published almost immediately after they were presented, which was fantastic. I'm going to show you the Flash registry here. The design, perspective, multi-center, single-arm study. I want to just make a quick point. Single-arm studies can be very helpful. We always want randomized trial, but when you get a lot of data that are good in a single-arm study, I think it's very meaningful and should affect how we feel about a disease state or treatment. So the objective here is to evaluate the safety and efficacy of the flow retriever system. The primary endpoint was major adverse events, a composite endpoint, including device-related mortality within 48 hours, major bleeding within 48 hours, intra-procedural device or procedure-related AEs, 800 patients enrolled, largest device registry for PE, 50 clinical sites in the US, and we had follow-up in almost 800 patients at 48 hours, somewhat less out to 6 months. Baseline characteristics here. You can see them. I won't read them all here. Just make a couple of points here. There were some patients with a systolic PA pressure greater than 70, 12.7%, meaning some of these folks had some other underlying problem contributing to pH, or perhaps that was underlying more chronic PE in addition to their acute PE. Can't get a PA pressure of 70 generally with PE alone. Lytics contraindications, 32%. High-risk PE, almost 8%. Most of these patients were intermediate high-risk PE, as you can see, with abnormal Aspesi, positive biomarkers, abnormal RV-LV ratio, and the vast majority were saddle and or bilateral acute PE. So that's the baseline characteristics here, folks. And here's some of the characteristics of initial femoral or common femoral access in nearly all cases here. Thrombectomy time, 43 minutes. Estimated blood loss with flow saver. That's critical, of course, because once the flow saver device came out, we could pull clot out and push blood back through a filter, much less blood loss. Adjunctive PE therapy in almost no cases, meaning thrombolytics, another device, etc. Rare post-procedure requirement for ECMO. Hospital overnights post-procedure, 3. Minimum of 2. No overnight ICU stay in the majority of patients. I think these last 2 points are really critical. Shorter length of stay, and sometimes no need for an ICU stay, for example, like we do need with thrombolytics. Here's some hemodynamic responses. These patients nearly all had hemodynamic data here. Mean PA pressure, not systolic pressures, mean PA pressure. So it doesn't look quite as impressive as you might think, because some of us are used to looking at echo systolic pressures, but this is impressive. A drop mean PA pressure by 7.6, cardiac index increase in the majority of patients here who had a drop, and drop in pulmonary vascular resistance here. And all of these were statistically significant, as you can see here. Acute clinical outcomes, heart rate greater than 100 in most patients to start with, and look at the drop we see. It makes us feel very good. We know from the German paper, the Hobon paper, that if your heart rate was greater than 100 per minute with acute PE at presentation, your mortality was 4 times increased. So great to see heart rate come down, and heart rate come down quickly post-procedure. Supplemental O2 in red means you required, and at 48 hours, the vast majority did not require any O2. Dyspnea and quality of life. This is an important measure here. So look at MMRC dyspnea score. So red is bad, blue is good. You can see in the baseline patients, the majority of patients either had severe dyspnea or moderately severe dyspnea, and that decreased very quickly at 48 hours and diminished to almost zero at 30 days, 6 months. And look at the pulmonary embolism quality of life scoring over there. Again, this is not the entire 6-item score we're looking at here. This is one of the items, probably the most important one, median frequency of complaint score. And you can see that drop over time, dropped and quite promising at 48 hours, but very low at 30 days and 6 months, very encouraging. And the key slide here might be safety and mortality outcomes here. Primary MAE, composite endpoint, 1.8%, that's 14 MAEs out of these patients. And of these 14 MAEs, 11 were major bleeds, and most of those major bleeds were hemoglobin drops, and some of those were actually before the flow saver was introduced, which is important. So really minimal in terms of major bleeds. 3 interprocedural AEs, as you can see here, 0.4%. And at the bottom, all-cause mortality, and this is really impressive all-cause mortality here. 48 hours, 2 patients died. At 30 days, 0.8%, 0.8%. Incredibly low mortality. Again, these are 50 experienced sites, but still very low mortality. CTEPH rate, 1.2%. Is that low? It is low. It varies. CTEPH rates vary in studies from the 1 point something percent range to up as high as 3.8%. Rich may give us some insight as far as that's concerned, and a little bit here on longer term effects, but these are really impressive results for this study. So which technique would you use? If you had a choice of large bore embolectomy and catheter directed or systemic lysis, extensive clot removal with large bore embolectomy, faster on table results for patients. On the other hand, clot dissolution variable with lysis, results take many hours, especially with catheter directed lysis. Maybe quicker for the interventionalist, but not quicker for the patient. Patients got to lie in the ICU with catheters in them. They're getting catheter directed lysis. So big advantage there. Thrombolytic contraindications, of course, don't matter with catheter directed embolectomy. Intracranial hemorrhage, not a risk. Not true with lysis. Critical site bleeding, not a risk with large bore embolectomy. Major bleeding rate low from Flash 800. 30-day mortality rate very low from Flash 800. And critical site bleeding is a potentially fatal risk. Major bleeding rate, I chose Seattle 2 to show, catheter-directed lysis study was 10%. 30-day mortality in the Geller study, which compared catheter-directed lysis and systemic thrombolysis, 7.9%. Seattle 2, 30-day mortality, 2.7%. Can't compare these two, these different mortality rates. These were not done in the same study. This is a little bit apples to oranges here, just to kind of give you an idea of 30-day mortality. Say that whatever Flash 800 showed, low mortality compared to some of the other studies, even though these weren't compared during the same trial. Just to give you an idea. You can rapidly treat clot in transit with large bore embolectomy. More than 700 cases treated to date with the FlowTriever device. Can be performed on ECMO. ICU admissions often not needed, as we mentioned. Larger catheter, which is an advantage, I think, here. And keep in mind with clot in transit, the FlowTriever device is FDA approved for that indication. With catheter-directed systemic lysis, you can't rapidly treat clot in transit. It takes some time. Higher bleed risk if done on ECMO. ICU admission always needed, smaller catheter. So I would also add one more point, that sometimes it's questioned whether or not large bore embolectomy can get distal clots. You don't have to go out distally with a large bore catheter to get distal clots. We often get them. We've got a number of photographs and cases we've seen where distal emboli are obviously and easily extracted with large bore catheter. So I want to thank these 50 sites. Again, these are sites that have experience with the FlowTriever device and all contributed to the FLASH registry. Great collaboration here getting this registry done, 800 patients. Finally, just as a wrap up here, I'm just going to mention Peerless here, our randomized clinical trial, FlowTriever versus catheter-directed lysis for intermediate high-risk PE. This study is already underway. Already a number of patients have been enrolled. And we'll also look at a non-randomized cohort who have contraindications to thrombolysis separately. Primary endpoint here, you can see the composite endpoint below. It's a win ratio composite. Cool idea, done in a lot of cardiovascular trials, not so much in PE trials. So I think we're stepping into a new era here where we're going to have an endpoint that makes a lot of sense and helps us sort things out, perhaps without doing studies of tens of thousands of patients. So exciting that Peerless is now underway. Conclusions here, I've kind of said these things very quickly. Flash demonstrated excellent results for FlowTriever, 1.4% major bleed rate, 0.4% rate of other major AEs. Real world population, I think it's important. Randomized trials are critical, but there's a lot of exclusion criteria. There's something to be said for real world patient studies. All-cause mortality, less than 1%. Hemodynamics improved on table. Vitals improved on table. RV size normalized, and clinical recovery continued through 6 months. So data from Peerless is going to help us out, answer more questions here, and that's coming. Finally, let me just finish with one quick slide of a case that was done. This was a low intermediate risk patient, abnormal RV, normal tensive patient. Troponin was normal, extensive clot burden, which has been shown to predict mortality in some studies, and happy ending here for me to finish. So I'm going to stop here with a little quote for you. Awareness of PE continues to be low. That was 2014, but I still think it's low. I'm going to stop sharing here now. And there's my colleagues there. I'm going to invite Rich Chanik now. We're really lucky to have Rich here with us. Rich is an expert in PE, an expert in CTEF, an expert in pulmonary hypertension, and he's probably the best person that gives us a nice perspective, not only of acute PE, but in this case here today, what to watch for in the future. Rich, great to have you here.
Thanks, Vic. It's a pleasure to be here. Great session. A lot to cover here in a short time because I was asked to talk about everything beyond the acute PE, and there's a lot that goes on beyond the acute PE. So we show this slide a lot, and very quickly, this is Eric Klock's sort of graphic of all the things that can happen after acute PE, and coined the term post-PE syndrome, which I think is a very apt term because it encompasses many different scenarios that can occur after a PE, one of which is chronic thromboembolic pulmonary hypertension. But we don't have time to cover this. There are a lot of long-term sequelae that our patients suffer from, including, post-traumatic stress syndrome, persistent exercise intolerance. And Aki Sista did a survey, and these are sort of approximate numbers that found 18% of patients in this meta-analysis that he looked at had ongoing RV dysfunction after over a year and a half, 11% with significant functional impairment. Walk distance was very, very low. And then the PERT consortium data that you may be familiar with showed, pretty high readmission rate. So there's a lot of things that can happen after the acute PE that patients can suffer from. So why basically would we have long-term sequelae? Well, we could have it because the clot didn't go away. So residual pulmonary vascular obstruction. And that can lead to a couple of different physiologic abnormalities, whether it's pulmonary hypertension, either arrest with exercise or residual dead space ventilation. And then there are other things, deconditioning, I mentioned depression. They could have worsening of their underlying disease that drives long-term morbidity. We're going to focus on in just a few minutes, really, this concept of residual pulmonary vascular obstruction and what that can lead to. And this is something that, I think we're all aware of. There's pretty good data, and this is from a few different studies that show that if you do have residual pulmonary vascular obstruction, we call it RPVO, you're going to have a higher mortality at both 6 months and even at 5 years, higher risk of recurrence, and then chronic symptoms of heart failure and dyspnea. So I don't think there's any question that residual pulmonary vascular obstruction can lead to abnormalities. And that's something we have to look for and hopefully prevent. And if we look at, and this is another nice study from about a decade ago, the degree of obstruction, and of course it makes sense that the more obstruction you have, the worse it will be. And you can grade the residual obstruction. So if you look at adverse events like death or symptomatic deterioration or recurrent events at 6 months, it really increased the more obstruction that the patient had on discharge, on hospital discharge. So it may not just be what happens late, but how much clot they actually leave with at the end of the hospitalization that can drive long-term outcomes. If we look at how often in general we see significant residual obstruction, this is old data. I used this in talks, over a decade ago that looked at imaging after an acute PE and found, depending on the study and the degree and the kind of imaging, upwards of 50% of patients would have residual abnormalities at 6 months. And this is older data. And subsequently, there have been a number of studies that have looked at similar things. And you can see the numbers there. Between 20 and 50% of patients have residual pulmonary vascular obstruction. And these series, many of these patients just got anticoagulation, some got thrombolytic therapy as well. So these are pretty significant numbers and measured late of patients who still have some degree of obstruction following the acute PE. This study I really like by Picard, because this is a study that had a pretty large cohort, that over 500 patients, this is a more recent study, who had acute PE and had follow-up VQ scans where they could come up with scores. And then of those patients, 256 patients, they could go back and they had initial scans where they could compare the initial degree of obstruction and how it affected residual obstruction. And you can see there in that little table there that about 3% of patients went on to develop CTEPH. You can see there about 50% of patients had at least 5% residual obstruction, and about 35% of patients had over 10% residual obstruction measured by perfusion scan late. And this is a more recent study with modern therapies. And then if you look at things that predicted the patients who would have significant residual obstruction of at least 5%, one of the things that we want to point out is that the initial obstruction, so the degree of obstruction they had on the initial scan, it was over 20%. That was in multivariate analysis associated with a odds ratio of over 3. So 3 times increased relative risk of having residual obstruction if you had an initial degree of obstruction of at least 20%. And I can tell you that of that cohort, 98% were treated with anticoagulation alone, did not get advanced therapies. So of course, the question then becomes, would decreasing that initial obstruction in that early phase affect this long-term outcome in terms of residual obstruction, which we know can increase the likelihood of CTEPH? And this is what we're trying to prevent. We're trying to prevent that clot on the left in that microscopic view, which is fresh, red, made up of blood elements, from not going away and becoming that lesion on the right, which is not a clot anymore. It's really a scar. It's a fibroproliferative lesion that occurs when we get incomplete resolution of acute pulmonary embolism. And this is something that we all deal with when we see these patients come back late with pulmonary hypertension, with persistent dyspnea. That's what we're trying to prevent by decreasing the amount of that fresh red stuff. So what are we talking about here when we're talking about CTEPH? Well, very simply, CTEPH is incomplete resolution of an acute PE leading to not just a chronic PE, but hemodynamically significant chronic PE. That's what we call chronic thromboembolic pulmonary hypertension. And that occurs, as Vic alluded to, in upwards of 2 to 3% of patients in studies. This is a more recent analysis by the group of Clock in the Netherlands, showing between 2.7 and 3.2% of patients who survive a PE will go on to develop CTEPH. This is all comers, and this is a European study. And obviously, the vast majority of these patients did not get advanced therapy. So that 3% is a number to remember. Now, what are the predictors of who will develop CTEPH? And how can we predict, or can we predict, in our patients with acute PE that we're trying to figure out what to do with, who is going to develop or more likely to develop CTEPH when we follow up these patients? And you can see here, these are our analyses of odds ratios of patients that were more likely to have CTEPH. So there's a number of medical conditions, inflammatory conditions, splenectomy, and then there are the PE-related issues, which may be more relevant to this session. The history of a previous PE, a larger perfusion defect, and an unprovoked PE. And that larger perfusion defect emerges as an independent predictor of the increased likelihood of developing CTEPH. The bigger the clot is, the more likely they're going to go on to develop this. The other thing that I want to talk about very briefly, because I think it does relate to, our concept of reducing clot burden in patients. However, we do it is the concept of dead space. And this is a pretty recent study from Tim Morris in San Diego that really looked at patients who had persistent perfusion defects. And some of these were relatively small defects, and they didn't necessarily have pulmonary hypertension, but they had persistent imaging abnormalities and some degree of exercise limitation. And what he found there is that the dead space, when he could measure it on cardiopulmonary exercise testing, using exhaled gas analysis and actually use a transcutaneous CO2 monitoring, that a significant number of these patients had elevated VDVT. This was a pretty consistent finding, and he's expanded that in quite a few more patients. So I think the concept, not to get deep into physiology, is that even if a patient doesn't have pulmonary hypertension, if you're left with residual perfusion deficits, that can cause symptoms, and it can cause symptoms through higher dead space ventilation. For the non-pulmonologists or physiologists, we're really then talking about inefficient ventilation, where the patient is breathing a certain minute ventilation, and some of that is going to non-perfused areas, which then will increase the ventilatory requirements, so the ventilatory inefficiency. And that can lead to exercise intolerance. So this, and Tim's doing a lot more work in this, I think is a very interesting area, and really gets to the importance of follow-up. And this is an algorithm that we use at our center. Many of you, I'm sure, have follow-up, but the key is to look at these patients after the acute PE, have systematic follow-up, looking for resolution of symptoms, whether they have persistent imaging abnormalities, looking at the physiologic effects of those persistent abnormalities on exercise capacity, cardiopulmonary exercise testing, pulmonary hemodynamics. And then you can really try to identify these patients early on, and hopefully, at the end of the day, prevent this from occurring. But if it does, at least recognizing these long-term sequelae. Thank you.
That's great, Rich. Listen, really nice job. I think it's kind of nice to be able to think ahead about what happens to patients with acute PE. And now that we know a little more about some of our flash results, know what can happen to people long term, it'd be great to get Jason Berger on. Jason's from Florida. He works in the ED, and he's going to talk a little bit about risk stratification. I think one of the great things about this little webinar we're doing now is it's very multidisciplinary, which is exactly what PERT's all about, right? We've got pulmonary critical care, we've got a seasoned interventionalist, and we got someone like Jason in the ED. So Jason, really glad you're here to talk to us a little bit about risk stratification, and fire away.
Thank you, Vic, and thanks everyone for being here this evening. So we're going to talk a little bit about risk stratification, kind of reading the lines between current risk stratification guidelines. As we all know, the risk stratification guidelines are a little outdated, and they don't always go to our patients. In the emergency department specifically, there's a huge gap between a lot of our guidelines and how we're treating these patients. So we'll just go through a quick workup through these patients. I think the biggest thing with our pulmonary embolism patients is we have to really symptomize the patient, see how they're kind of acting right off the bat. A lot of times these symptoms are kind of masqueraded by another disease state, a STEMI, something else causing their symptoms. So when we have that confirmed diagnosis of the PE, the hard part is kind of characterizing these PEs. Is this a low risk pulmonary embolism that is really not going to have any statistical difference if we treat or non-treat? Is it a submassive intermediate high or intermediate low, or is it a massive PE? That's a big thing most clinicians have trouble with, is kind of characterizing these patients. Just like Vic said, his last slide there was a patient that had intermediate low risk. So these patients are the ones that were kind of sneaking by and kind of curving through these. So these patients are kind of hard to treat across the board. Now, like I mentioned earlier, risk stratification, it's not great, but it's helpful to some of us. So we have whatever stratification tool you like. Is it PESI, MPESI, Geneva, PERC, Wells, whatever one you like can kind of help you guide what test you're going to do and see what system you want to use. But the question is there people that fall through these categories that don't really get into the right person? So obviously, when we're talking about pulmonary embolism, the imaging study of choice is a CT angiogram. That can be done at most facilities across the country. We can use VQ scans if we don't have an option for a CT, but I think most centers do have that. Echocardiogram can be helpful in this sense to look at the RV-LV ratio, but most of the time we use CT for this to begin with as the BAT. And then our EKG can be very helpful. If a patient comes in with a STEMI, they have a clean coronary, they have a clean calf, you really want to be looking out for other reasons why they have EKG changes, pulmonary embolism being one of those characteristics. Now, a lot of times clinicians, especially in ED, don't really look for the concomitant DVT. We kind of started that in our practice 3 years ago, and it's amazing to see the amount of patients that are having concomitant DVTs and pulmonary embolisms, vice versa. Now, a lot of the times when we're talking about pulmonary embolism, lab work is kind of that second thing that we think about, but sometimes it can be quite helpful. Troponin obviously is very helpful in this situation. One of my favorite things is that troponin that doesn't make sense. Patient that comes in not having chest pain, but having some other symptoms, my troponin is my guide in this situation. If the troponin doesn't make sense, I always have a high suspicion that the patient has a pulmonary embolism. Lactic acid has become a very big factor in the last couple of years. Just like sepsis, the increased lactic acid can indicate a higher mortality with these patients. Now, a lot of the times, if these patients have a small pulmonary embolism that really is not going to be treated with any type of intervention, we still discharge them on the DOAC of choice. But in our practice, what we usually do, if they do have a big clot that having some other risk, the intermediate high, intermediate low, or massive, we're going to start these patients on a heparin drip from the ED, and then we're going to communicate with our PERT team or whoever we're going to speak to, the end game interventionalist. So the big thing is, like Vic said, a lot of these patients have contraindication systemic lysis. So you have to be careful with that patient population. Now, an old school way of thinking, PE risk stratification is really anticoagulation or thrombolytics. And the problem with both of these is there's risk to both of them. So in the old days, you had to kind of think about, okay, which is the lesser of the two evils? When you have risk of just anticoagulation alone, you have about a 6 to 15% all-cause mortality in these submassive patients, and then 1/2 to 1/4 of these patients in massive patients. So if you have 1 to 2 to 1 1/4 of your patients have that significant mortality, it's really not a win for anybody. Versus the complete opposite side of that spectrum, if we're giving lytics, well, like Vic mentioned in his slides, we have about a 9 to 22% chance of major bleeding. And when we're talking about intracranial hemorrhage, this is those fatal patients. We all get into medicine to help patients. But what about that patient that you try to help and then they have a bad outcome from that intracranial hemorrhage from a systemic thrombolytics? The typical overlooking of this is very significant. So usually that risk stratification does not help with these patients. So when we have a better outcome and we have better tools to help the patient, the question is really, why not with these patients? So I'm sure you all have seen this before. This is the RV death spiral, I like to call. But the big thing is, if you just kind of look at this as a broad statement, RV dilatation is really the first step to happen. But everyone really gets worried about these when these patients get hypotensive. When a patient has truly systemic hypotension, we are running really low on time with these patients. So that makes, when a patient becomes hypotensive, they're automatically going to be a high risk patient because the RV is already saying, hey, I can't work anymore. So our risk stratification tools here, really with the recent study, has shown that even with an SPECI of 0, the patients can present with cardiogenic shock. So this study done here that was done at Porcal was showing that 40% of normotensive PE patients are actually in cardiogenic shock. And that means that their cardiac clearance was less than 1.8. And then on our flash registry, our 20% of these PE patients with SPECI of 0 were truly in cardiac shock. So that's kind of a staggering statistic. So when we have that truly hypotensive patient, really we're in trouble. So this is an algorithm that we use at our center here. So let's kind of just run through this together. So we have our confirmed pulmonary embolism. We start our anticoagulation, whatever one you decide at your facility. Like I mentioned earlier, we start heparin at our facility. Now, if the patient's hemodynamically unstable, I like to use the term red light, green light, and yellow light, just like the traffic light. So our red lighters are these hemodynamically unstable patients. So these are the patients that are systemically hypotensive, they're requiring pressors, or they have severe bradycardia. We've seen a lot of patients in the last couple of years with bradycardia versus that tachycardia. These patients automatically are a red lighter and they become a high risk. And these patients, we need to consult for our PERT team faster and get these people to intervention. Now, when we're talking about the yellow lighters, I like to call, there's 2 in that situation. That's the intermediate high risk and the intermediate low risk. And the big thing with these is based on the CT scan. So if the patient is intermediate high risk, they're going to have both positive, meaning they're going to have an RV to LV ratio greater than 0.9, and they're going to have elevation of their cardiac biomarkers. So these patients are truly sick. Now, those patients we know are a slam dunk and we know how to treat them. The hard part are these yellow lighters, the intermediate low risk. So they can have 1 or none of the positive. So they can have a normal RV to L ratio, and they can have elevation of their trope. Most of the time, they're going to have one. These patients are the one that we have kind of a harder time treating, but like Vic showed in his picture, that patient had a massive clot burden. So these are those intermediate low risk. Now, if they have neither, these are what I call the green lighters. These are these low risk patients that most of the time we're just going to start them on anticoagulation alone. Now, if we're going to our thrombolytics and we're going to our next algorithm, let's talk about those high-risk patients. These are the ones that scare everybody. These are our postcodes. These are the ones that come in cardiac arrest, and we're trying to get these patients stable. If we truly can't move these patients, then we have no other option. We need to consider systemic TPA or ECMO. We could still do a thrombectomy later on with these patients. We need to get them for intervention as soon as clinically possible. Now, the intermediate high risk, I talk about those. Those are usually quite easy. They're going to have elevation of their troponin, and they're going to have an RV to LV ratio greater than 0.9. But really, let's focus in on this intermediate low risk. These are the ones that kind of slide by a lot of us. So things that I look at, do they A, have a large or central clot burden? If they have a large clot burden, they have about a 17.6% increased risk of mortality at 6 months. If they have a central clot, they have 2 times the risk of PE-related mortality. Now, what else do I look for in the ED? How do they look? Do they look well, or do they look like they're about to crump on us? What's their heart rate? What's their respirations? If they're truly not looking bad, then that symptoms help with it. Are they hypoxic? It makes a huge difference to patients on a nasal cannula at 2 liters versus a patient who's on a non-rebreather at 15 liters. How severe is that RV to LV ratio? Honestly, we use the CAT scan for that, like I mentioned. If they have a really large ratio, my concern is significantly high. Like I mentioned earlier, the lactic is a huge predictor in increased mortality with these patients. Do they have a concomitant DVT, or do they have a clot in transit? These are really, really significant factors that we look about with these patients. Now, if their lactic is elevated, that adds a 5 times risk for PE-related complications. If it's greater than 2, if it's greater than 3.8, 2 to 3.3%. And if they have a concomitant DVT, they have a 4 times risk of PE with these VTE related mortality. Now, the low risk patients, they're going to still continue their anticoagulation, and we're going to monitor these patients for continued symptoms. Thank you for my time.
Jason, this is really unheard of, to have 3 speakers in a row all stay on time. That's really unbelievable. That's really nice presentation, Jason. Really, I think it's a great lead into where we're going next, to talk about these complexities of risk stratification. And now we've got Michael Jolly, who's a really experienced interventionalist. Michael, it's great to have an interventional cardiologist here that's had the kind of experience you have, to show us some cases, which I think is what everyone really wants to hear. So we'll do your cases, Mike. And you know, you probably get a little bonus, Michael, since we were all so good. You may get an extra minute or so if you want it. So
that's good. I'll definitely be over. I don't have to be, though. Thank you. I actually really liked your slide, your discussion, Jason, because you're kind of pushing on the imperfections of the risk stratification. I actually think a risk stratification leaves a lot to be desired, and we can probably go into that in a minute. But I was really asked to maybe pick some cases that kind of challenge maybe the status quo. And that's not so much these cases, but I'm going to tell you the cases that I picked, I'll just get to the punchline. They don't always have a great happy ending, okay? We present a lot of nice, flashy cases, but I was just going to get real today and show the kind of cases that we all see every single day in our hospitals. Let me start with this one. I don't see the timer either, by the way, so if I start running close, let me know. The first patient I'm going to do is a 47-year-old. Okay, hold on 1 second. Sorry, guys. Got to go back here. Okay, 47-year-old gentleman who actually is an outpatient. So that's not our usual entry with PE. He's an outpatient with known metastatic melanoma, and he has brain mets, okay? So you can kind of see where this is going. So he kind of saunters into the outpatient radiology department for a kind of a follow-up brain MRI to kind of see what the status of his lesions are. And they kind of do his usual intake, get his vital signs, and they see him walking in, and he's just obviously quite short of breath. he's dyspneic. They put a pulse ox on him, and he's just barely cresting 70% SpO2. His vital signs otherwise are okay. He might have been slightly tachycardic, but low level, like 100, 105. So he kind of gets shuttled over to the ER, right? The usual kind of, you can't stay here. We need to figure out what's going on. And it wasn't a big mystery. He got a CT scan done, which I'll show you. He even had an echo. We had time. He has a big blown RV, positive troponins, and a little bit of clot left. So the kind of CT scan that you might imagine on this, but maybe more impressive than you might imagine on an outpatient. So here's a guy who's absolutely socked in, both sides, saddle pulmonary embolism, large central thrombus burden. And you can see the radiologist did the favor of measuring the right ventricle for me, but suffice it to say, he had a very severe RV dilatation. So all the kind of stuff you would put together as an intermediate high risk if you're using what Jason kind of described as the ESC criteria. And I usually like to stop here and say, what would you do? And I kind of do this for us too in our system, because we've changed pretty dramatically in the last half a decade on how we approach these patients. And I don't know if there's a right answer, but I will tell you, we're starting to focus in certain areas like large bore thrombectomy and getting away from the poison of thrombolytics when we can. I think many of us would start heparin. I don't think that's controversial. I think any form of lytics, obviously in someone with known intracranial masses, is challenging. But we have lots of other procedures that we could potentially offer this patient, including palliative care. And I will tell you, years ago, that might be where we land. I wasn't sure exactly who the audience is, but I did put this slide in basically to show the procedure and how we access. So, these are common femoral vein procedures, generally speaking, and we kind of get up safely through the heart into the pulmonary arteries and then over an 035 guide wire. We pass, in this particular case, it was a large bore thrombectomy with an Inari flow retriever. And so based on the CT, we kind of target where we want to target. This is a very efficient procedure. Just prior to doing that was kind of a stock image just for the purposes of instruction. But, this was the patient's pulmonary angiogram, which I really don't actually do that often anymore. And we can do many of these procedures with hardly giving any contrast. But in this case, it's no surprise to anyone who actually saw the CT, which is to say his right lung is completely offline, except a little bit of the right upper, and the left looks very similar. So the efficiency of non-thrombolytic large bore thrombectomy is demonstrated in this slide. So I did one single aspiration, and I do want to show this, and I like to show this slide because it really shows the rapidity with which you can actually achieve fairly rapid results. So the patient, as I'm kind of back on the table messing around, is already kind of describing how much better he feels. And we were able to really bring out the vast majority of the thrombus in his right pulmonary artery with what is that? Maybe 30 cc's of blood, which we probably recirculated back to him through flow saver. But a very nice example of this strategy, which we tend to use, especially in patients with such a large proximal central burden of thrombus, you can see. So this is a case that we did, I want to say 6 months ago. So I won't make you watch all this. Let me go to the next slide. So the very next picture, of course, you can see his whole right lung is back online. And it's interesting because many times just a single segment, you can so much dramatically affect their right ventricular afterload that they're kind of back on the Frank Starling curve if they're in shock, or if they're not, they're clinically feeling quite a bit better. He also had the left lower lobe that was offline. And so we went after this next, and I won't belabor it, but just a couple of quick checks, make sure we're in a safe spot. We used one of the Inari flow discs, which is maybe the flow retriever 2. I would like to, for Inari's sake, say that's off label for this indication as of right now. But nonetheless, we were able to get the left lung back online and had a very nice result. Now, listen, this guy has metastatic melanoma. This isn't going to have a happy ending, and none of us really expected that it would. But I will tell you, this guy left the hospital. He went home, and he lived for, I think, another 2 months before he finally succumbed to his metastatic melanoma. But this guy lived at home. He had young kids. So he's a guy that, we do so much more for so many, so for patients. It's just a nice representation of kind of what we can do in the modern era of treatment of patients. let's see, I have 4.5 minutes. I want to do this case. Also, maybe not the best case, but I think it can show you, as we think, like Jason described, you know, at least within our own ERs and hospitals, of how do we deal with PE. In my case, we're kind of looking at it as a system, and I'm a cardiologist, as Vic said. So I kind of think of PE like I do STEMI, and we've kind of built our system on the backbone of how we think of STEMI or trauma or stroke and stuff like that. So this is a woman who's 69 years old. She's got several risk factors, COPD, obesity, but most importantly, she was in a skilled nursing facility. And she was in a skilled nursing facility just because she had a little infection and didn't have the kind of care she needed at home. So she was on appropriate Lovenox prophylaxis, which, you know, it's in a skilled nursing facility. We should be pretty happy that she was getting anything. But then she had just been discharged home, and there she was, kind of walking to the bathroom, and she had syncope. Syncope was witnessed. She struck her head on the coffee table, but she didn't lacerate. She woke up and was doing okay. She got transferred actually in as a trauma to the local hospital. And this was up high in what's called Mansfield, Ohio. I'm not going to go through the map of Ohio, but it's about an hour and a half away from Columbus, where I am. And they kind of went through the standard kind of CT scan trauma protocol, and she started getting sick. She arrested on arrival. Things started not going the way normal trauma would, and they actually saw the pulmonary embolism. Now, this woman, they didn't have capability of taking care of this there, and I really didn't want to give her IV lytics, and she was quasi-stable on very low-level vasopressors at this time. So I dispatched the helicopter to go pick her up, but unfortunately, as they were getting her onto the helicopter, she arrested again. So now I'm pretty far behind the 8 ball here. And just like Jason said, I mean, you know, we're not averse to using lytics. It's not maybe the best thing to give all patients, especially someone who just hit their head, but we did. I felt I had to get some therapy in her en route, but she got lytics, and you know, as she's flying to my cath lab, she's just deteriorating down the RV shock spiral that was shown in the last session, and now she's on escalating doses of pressors. She started on, I think, 5 of norepi when she left the facility. Now she's on 40 and epi as well, but she's reactive. She's moving, and she's saturating reasonably well. So this is me getting access, quickly throwing up a swan, getting her hemodynamics, and doing the procedure as per usual. These are screenshots of that. We were able to quickly, I'm not going to show pictures of amazing clot, but we're able to quickly kind of get the right ventricle back online. The left PA was cleaned out. It's back online. And this lady actually left the cath lab on 5 mics of norepinephrine, saturating 100%, and looked great. And within 12 hours, now she's fully off of pressors. Unfortunately, she had a noxic brain injury and actually never fully woke up. But I wanted to show this case because these are real cases. These are the kind of cases that come into our hospitals every single day. And I think the one thing, the guidelines, they're just, I mean, the last real chest guidelines for this were published in 2012, and there's been a recent update. And of course, ESC has their guidelines, but there's so many black holes in these guidelines that don't address the kind of patients that we see. What about the patient who you can't give lytics to? And I think we can talk about this when we get into the discussion, but that's a real large portion of patients, which was confirmed yet again with your 800 patient subset. And we have to have a way to flex to take care of these patients to really achieve the results that, you know, we've always relied on, systemic lytics or whatever. It's just not realistic in so many patients. And so to stay on time there, Vic, I'm going to jump off here and let's go into discussion mode, huh?
Mike, that was great. I love that. I love that melanoma case. I mean, you gave this person who's going to die 2 more months with their family. You know, I mean, that means a lot. A lot of people would say, cancer patient, sorry, you know, let's just put this person over here and hope they get better in anticoagulation. I think that's awesome.
Well, let's be honest, Vic. I mean, in so many hospitals, they're going to look at this, they're going to criticize you for, oh, you're doing an intervention, but they wouldn't think twice about putting a Pleurex catheter in him, right? If he couldn't breathe. I mean, that palliative maneuver, they wouldn't think twice about sending him to the OR for something like that. And yet we're going to be criticized for giving these people lives. Now, certainly in the old days when it was lytics or not lytics, I get it. Of course, that risk benefit ratio is dramatic and it has to be addressed, but that is changing, right? That's as soon as you take lytics out of the equation, it doesn't matter which company and which device, honestly, you're talking about. It's the lytics, right? If you take the lytics out of the equation, you've taken someone from a, say, 10% bleeding risk, 2% intracranial hemorrhage risk, down to now we can at least see with kind of the contemporary data sets, you know, less than 1% I mean, now we're in the range of, we're in the we're slightly worse than heparin, maybe, so it's a different playing field.
It's really well put, Mike. So just to add to that, and then I'd love to get Rich and Jason's thoughts about this. So based on what you just said there, we got good safety data. What about an intermediate risk patient? What would make you do an intermediate risk patient? There's certain things that make you say, I'm going to do this patient, extensive clot burden, RV abnormal, anything that makes you say this patient's got to go for a procedure.
I'm sorry. So one more time, Vic. I thought that was for me, huh? So
Oh, sorry. Okay, sorry. So yeah, what would make it? Let's look at intermediate risk patient. You showed some great cases there. How about an intermediate patient comes in, got an extensive clot burden, RV's abnormal, heart rate's 110, 115, but they're not hypotensive. How do you feel about those cases?
yeah, listen. I honestly, Vic, I learned this from you at a PERT meeting. God knows when. 5-6 years ago. I didn't learn it from you, but you confirmed it for me. And it was really important. Our surrogate markers for risk are so poor. I'll be honest, most of my decision comes to the good old fashioned vital signs, because if you're being driven, if you're compensating with the tachycardia, the problem with the intermediate category is you have patients with a little bit of clot and saturating fine, normal blood pressure, sometimes a normal heart rate. Let's be honest. That patient is in the same category as the patient that I just showed you, the patient with the cardiac index of 1.5, who is compensating. So technically speaking, their blood pressure is 100 and they're not on pressors, but they're not even the same stratosphere of patient, yet we categorize them the same. Now, yes, we have low risk and high risk intermediate, but I listen to their vital signs. I look at their saturation. I look at their heart rate, and I put it all together. And of course, you have to look at the patient. You're going to treat the 40-year-old mom of 3 different than you're going to treat the 85-year-old nursing home, palliative care patient. Obviously, that plays a role too. But all else being equal, the heart rate is good. The heart rate and their symptoms are going to drive me to do a procedure.
Great, Mike. Great. Well put. So, Rich or Jason, any thoughts about these intermediate risk cases? Is there anything that would make you say, this person's not hypotensive, but you know what? I'm worried about them. I want to be more aggressive.
I think one of my favorite cases, I think, was an intermediate low that ended up turning to be a great case. The guy was sitting, talking like us, having normal conversation. And I brought the interventionalist down. He had a large clot burden on both sides, and he was having a normal conversation like this. Me and the interventionalist were going back and forth. His patient needed intervention. And the gentleman literally said to both of us, he said, while you two are talking, can I go to the bathroom? So he stood up, had a urinal, and desaturated right in front of us, 100% to 89%. So that is he's a perfect candidate why this risk stratification is old and outdated. He really would have been an intermediate low risk, and he had a major problem that just wasn't there yet.
Sure, yeah. And I liked your algorithm, Jason. I think you're going to get some requests maybe for your algorithm. I think it was a well done algorithm. Rich, any thoughts about how you risk stratify? What makes you might say this patient's not hypotensive yet, I'm not comfortable just anticoagulating? Any thoughts about that, Rich?
Yeah, no, I certainly agree with what the other guys have said. I think that, having seen enough patients with, pulmonary hypertension, chronic, you know how sensitive the RV is to afterload. And I've always been impressed that, we show the pictures of the massive clot, but, even just to go in there and open up, decrease afterload by, 10% with let's say a thrombectomy, that little bit can put the RV in a better position. And so, you don't want to overthink it. If they have any evidence for the RV not being happy, and especially in a patient who doesn't have the reserve, people have said they can look good, but, if they got residual DVT and, it just takes a little bit more, a heavy bowel movement and then, you're dealing with an emergency. So, to be honest, this is actually a lot of why PERT started, was because, these patients may look fine, but when you get a group of people together, you start to think about it and you come to different conclusions.
Right, Rich, and you were right there when PERT started. That's awesome. Yeah. When you mentioned the clot in the leg, that's another thing that I think deserves some thought, some attention. The Japanese study, the command study, was kind of a cool study. Showed you've got acute PE and you have clot left in your leg, your mortality is twice as high.
Right.
Same, David Jimenez's study, 2010, published in Chest. If you've got acute PE, clot left in your leg, it's approximately your hazard ratio for PE related mortality is 4.2. So to me, there's a lot of things we can look at there. Guys, what about lactates? You think, Jason, you're in the ED. Are people ordering lactates more in PE now than we used to? You think, to help make decisions when they're not sure what to do?
I think if they're in the right forum, yes. I think it's kind of a new school technique of way of thinking, but I think around here, most centers are starting to add lactic into the ED protocol for PE, yes.
Gotcha,
Yeah,
gotcha.
I totally agree, Vic. I think that I think that's important, and we're starting to do it a lot more because we keep getting like today, just today, I had a patient, and we've all had this patient. They weren't doing the patient has a DVT and she was diagnosed as sepsis, and we all have sepsis alerts in our hospital right now because they're hypotensive, and her creatinine was going up, so they didn't want to do a confirmatory CT, and a lactate was also going up, and we finally pulled the trigger, and she's dying of obstructive shock now. So this is the kind of thing that might uncover these normotensive cardiogenic shock patients that we see out there when we drop a swan in them during this procedure, and we find that even though they quote look good from the door, their index is 1.5 and they're barely compensating.
Gotcha. Just call attention. I've answered some questions in the chat there that I've answered. Bruce David just made a point about this low molecular heparin versus standard heparin. I'll just answer that real quick. I think Bruce understands this very well. He understands better than most. But I just say that I think low molecular heparin makes great sense. It's therapeutic in 3 or 4 hours, and you're good for 12 hours. If the interventionalist or somebody is concerned and maybe that wants to use heparin, worried about bleeding, shorter acting drug, then do it. Bruce makes the point that in really sick patients, there's questions about whether the low molecular heparin is going to be absorbed adequately sub-Q. So great points by Bruce. I think you got to be those studies aren't big randomized studies, but they sure suggest there could be problems in really sick high-risk patients. Good points. So
can I chime in on that too real fast?
Please,
Because I was
please,
just
Mike,
at Veins, and this actually came up in Veins, and I think I learned something that I think we all intuitively know, and that is historically we've also used unfractionated heparin. We've been moving away from that. In the same way we've moved away from TPA when we give lytics, I tend to use tenecteplase. When you give enoxaparin in the ER, it's easy and it's one and done. The problem is when you look at patients who've gotten unfractionated heparin started in the ER, there's a huge subset of patients 48 hours later who still aren't therapeutic. And with the decimation of all the nurses and all of our respective hospitals across the country, I think this is a real issue. If you can do things that don't require a nurse to draw a PTT, just a nomogram and dose, it's going to be so much safer. And I think most interventionalists are fine with it.
And we see a lot of folks that are morbidly obese, and those morbidly obese patients, the Hurwitz paper showed these patients do not get adequate boluses. Someone ends up based on their weight, 80 units per kilogram bolus, needs a $12,000 unit bolus. People are afraid to give that much. They underdose them. So I think in the morbidly obese, that's a bigger problem even with standard heparin. So guys, well, let me ask you a question, Rich. You would give us a nice discussion about post-PE syndrome. What do you think about the risk of CTEPH? I mean, Flash 800 risk was 1.2%. Now that didn't go out 1 or 2 years. It's still awfully low. What do you think the rate of CTEPH really is, Rich? If you had to say based on your knowledge base and the studies done.
Yeah, no, I think that 3 to 4%, is probably pretty accurate. And there's multiple sources that have shown that. I think one of the challenges, is that a lot of patients who are just labeled as incident patients are really prevalent, and we all seen these patients coming in with so-called acute PE, but as you said, their PA pressures are high and there's clearly a chronic component to it, or at least subacute. And so, I think that is about right, 3 to 4%. So yeah, the 1 point something percent is certainly provocative. Obviously the next step is, are you actually decreasing CTEPH by early intervention to remove the clot? And I think the jury's still out on that, but it's certainly provocative data.
Yeah, well put. Yeah, it is provocative. I think we know if basically the data you showed is true, if these larger clots cause more long-term problems, it does seem to make sense. Get that clot out. It's kind of if this, then maybe that. But yeah, we'll get more data. Maybe we'll get some from Flash 800 and some from Peerless. We'll see what we find out. Colleagues, we've got a couple minutes left. Any burning comments anyone would like to make right now? I can always come up with more questions and comments and things here, but anything you'd like to say about our webinar today, these kinds of patients? I think to me, the intermediate risk patients are really the intriguing ones, because these are the ones the guidelines are telling us, ESC and ACCP are telling us, you got to sit and wait for deterioration, which seems to me, if you have a safe option and you've got, an operator that understands how to do these kinds of things, it just doesn't seem to make a lot of sense. If you've got an all-cause mortality of 10 or 15% from acute PE, intermediate risk PE is in the range of 5 to 10%. To not do something when you've got a procedure, the risk of mortality seems to be so low. So I think that seems to be the holy grail to me for acute PE. You know, how do we and guidelines tell us, again, ACP says you wait till someone deteriorates. Is that a heart rate of 90 to 100, 90 to 110, blood pressure drop of 120 to 100 systolic? You know, I mean, how do we decide what deterioration is? If you're going to wait, if our pulmonary colleagues, which are the ones often that say, you know, we're not willing to go ahead yet. We're going to wait till they crash, and then we have to call Mike in the middle of the night instead of at a decent hour. Any thoughts about this sort of deterioration thing? I mean, if someone's making you wait, what tells you that someone's deteriorating? I mean, I'm not sure there's an answer. I think, you know, to me, if someone goes on oxygen, is not on it, you know, they're sitting there for 24 hours, no one wants to do anything. They go on O2, that's deterioration. Heart rate goes up, that's deterioration. They feel worse. They say, look, I'm a lot more short of breath than I was 8 hours ago. To me, that's deterioration. But yeah, I kind of hate to wait for deterioration. You know,
Yeah, I mean, this is the whole problem. I mean, you know, until we can precisely predict who's going to deteriorate, which we can't, you know, you're guessing in a way or
Sure.
praying, whatever your choice is. So, you know, if you have if you have an intervention that's safe and is feasible, until you can predict, you know, exactly who needs it, you know, you are on the side of doing the treatment. That's,
Sure.
you know.
You know,
Mike,
Vic,
Yeah.
this is such an important point, and I'm sorry to, I know I'm a cardiologist, so I live in the cardiology world, so I have to use the comparisons that are relevant to me. But you know, when we have patients who have positive biomarkers in the ER who may or may not have chest pain, I'm getting called to, do I need to take them to the cath lab? Do you take them to the cath lab and look at their LED? And I get called for everything. And I'm sitting there thinking, man, the data is not that strong, you know, here, if the patient's clinically stable. And our problem with PE is what you just said. We don't recognize clinical deterioration, the upfront stuff. And when you're down that cardiometabolic shock spiral, it's only when your blood pressure is persistently low. And we're so far behind the 8 ball when that happens. This patient now is maybe not even a candidate, because that patient may not be someone I can lay down. The patient I did earlier today, while she was hemodynamically unstable, she was also, you know, she wasn't perfusing her brain. She got a little sick and unruly on the table, and that is not the time to do this procedure. So I've converted someone now to someone who is safe to do maybe 12 hours upstream to now someone who's really struggling 12 hours downstream. And that clinical deterioration is a big deal. And I think we are very good at diagnosing PE now. I mean, I think the advent of the PERT team and honestly, the ubiquity of the CT scanner in every freestanding ER in the country has made this not super complicated to diagnose, but it's when to refer and when to treat. We've got to get there. I think that's the next phase of PERT, really.
I'd like to add on that on top of what Dr. Jolly said, but like we're arguing over these patients. We really want to do the best thing. If our numbers and our statistics are so low, why not intervene? You know, like he said, we're getting to a level that we're just maybe under heparin or above heparin. So why wait for the deterioration? That's really what's going to cause these patients to have some sort of significant decline. You know, that's why I think we're so aggressive now, is we're doing the right thing for the patient. It's good for the patient. It's good for the operator. It's good for the hospital. Why not?
Yeah, I agree. And Jason, I think your point is spot on. And the problem is that people don't actually know. People don't know what's capable of. Everyone's still married to the thought that, you know, the guidelines say I need to use lytics, or, you know, and only when they're in shock. Well, that we've got to get away from that. Obviously, that's not the real world anymore.
And I think the guidelines all say, ASH, even the conservative hematology guidelines, ASH, ACCP, ESA, they all say guidelines are just that. They are not the standard of care. They don't dictate what they do, what we do. They guide us. So I think that's the way to think of guidelines. I think sometimes guidelines are behind the times. There's a nice paper written in 1989 that said clinical guidelines can be harmful. You know, a lot of times technology is ahead of guidelines. They're not published for another 2 years. So I think they're very useful in many cases, but I think we have to kind of use the art of medicine still and use our registry data and use the data we have to help us make decisions until guidelines catch up and until we prove beyond a shadow of doubt to other people that the last question I was going to ask, how come on the screen PERT's backwards on my name and forwards and everyone else's? You know, PERT's written backwards like I'm some kind of anyway, guys, we got like another minute. This is an awesome conference, have a multidisciplinary group together talking. Any last comments anyone wants to make in our last minute here?
I would just congratulate the data set that you presented. Honestly, in full disclosure, I didn't attribute any patients to that, but what's really good about that 800 person cohort is that it's reflective of the real world. I mean, I can tell you, it's frankly a little bit sicker when you compare it to like ICOPE or, you know, you have what, 7 or 8% of high risk. That was a little bit higher than there. You confirm what we all know, which is that the incidence of patients who are lytic contraindicated are real. And these are patients that have been ignored entirely up until the advent of non-thrombolytic based devices. So I think it's really important.
Great point, Mike. Listen, I want to really thank the PERT Consortium for putting this on, and thank my colleagues at Inari for teaming up together and doing this. Really great discussion by all of you. Thank you so much, everyone, and I look forward to seeing everyone and maybe another webinar soon. Okay.
Thanks, everybody.
Thank you.
Take care, guys. Thank you.